Thank you. Good afternoon, ladies and gentlemen, and thank you to the organizing committee for this opportunity to speak today. I'm speaking on behalf of my colleagues and the consortium, and the talk today is on the HCV self-testing as a gateway to identification of amongst key pops with no previous screening experience. Firstly, I'd like to acknowledge the study participants for their willingness to participate, our funders, Unit Aid, our lead consortium partners, PSI, Dr. Karen Hudzold and team, Anova Health, Dr. Nomfundo Nklapo and Dr. Manyuchi and team, and my team at Ezintsha. So HCV self-testing is something quite new within the landscape of screening and testing for hepatitis C. But self-testing in general is not something that's new. The global impetus for self-testing started about a decade ago when HIV self-tests were starting to come to the market. In 2017, the WHO provided the first recommendations for self-testing, and this was for HIV. And by the end of 2023, we have 104 countries which have now adopted national policies on self-testing, with 63 routinely implementing, with a whole lot more currently in the pipeline. Much of this drive globally has been owed to the success of the Unit Aid funded STAR program, which provided valuable lessons that we've taken from HIV and started to incorporate them into HCV. So in 2019, as part of a FIND-funded program, I was evaluating products for WHO pre-qualification. Ezintsha, we were conducting assessments on two candidate devices, one blood-based and one oral-based test. We were acting as a low prevalence country for HCV, which everybody knew South Africa is one. Issues then arose with recruitment in the high prevalence settings in Spain and Georgia. And we were requested to try and find a pocket of high prevalence setting within our Key Pops program. And not knowing too much about this space, we approached Anova Health Institute to help us recruit from their key population program to make up the numbers. We were given a target of 100 participants to enroll, and what we found absolutely floored us. Amongst the 100 participants that we enrolled, we found 81% antibody positivity within the program. These were patients that were outside the cohort of the program that they were currently looking at. And this definitely made us all sit up with a lot of concern. So the context of our study, the disease burden for HCV in South Africa is quite low. Everybody knows South Africa for its HIV burden, and the percentages there are quite alarming. Naturally, HIV takes precedence over almost any other disease state in the country. However, HCV at about between less than 1% amongst the general population didn't raise too much of a concern. However, the published rates of positivity amongst drug use populations was between 30 and 40%. And then we looked at what we had done in this assessment and said, these numbers really don't coincide with each other, and we really need to start digging deeper. So leveraging of the success of the HIV self-testing program in reaching individuals through non-conventional methods, we started looking at implementation of a HCV self-testing program with two different types of sites. We looked at facility-based direct distribution and community-based distribution through harm reduction, needle and syringe outreach programs. The objective of our study was to measure the effectiveness of HCV self-testing for uptake, linkage, confirmatory testing, diagnosis and treatment amongst key pops within the inner city of Johannesburg, to assess participants' adherence to recommended guidelines on treatment, and very importantly, to assess lay users' interaction with the self-test in terms of usability, effectiveness, and efficiency. So could somebody from this very marginalized population actually perform a self-test? Could they do the test on their own? Could they interpret the result correctly? And that was one of the major findings. Would it be acceptable amongst this group as well? So in total, we recruited 1,567 participants, with the majority being male, and the majority coming from the people who inject drugs. Education level, you can see that most have some level of schooling, going up to a high school of education. But the number that I really want to draw your attention to is the self-test positivity rate of 63.7% that we found amongst this population. These are antibody tests that we were using. The split between oral-based and blood-based testing is shown as well. You can see the mean age of participants recruited was around 32 years of age. Yeah. So 998 reactive results representing a reactivity of 63.7%. Yes, so were these active infection or non-active infections? That was the next thing that we looked at. So of the 998, 740 were co-infected with hepatitis B or HIV and had early advanced liver disease, as indicated through high APRI scoring. So in terms of the testing outcomes, and this was now what really made us stand up and take notice, was the confirmatory testing, and the percentage that were PCR positive from the cohort was quite alarming. The main challenge that we faced was in South Africa is that DAAs, whilst can be procured, the availability is quite low. And so we had to go in and procure all of the DAAs through our own funding mechanisms, through the STAR program. And this came with a whole host of various challenges. Treatment completion was dependent on provision of psychosocial support and whether the patient was on opioid treatment. So this program continues, so those numbers could alarm you in terms of the linkage into care, but the patients are transitioning into the routine program that's currently occurring. In terms of usability and performance, which were very important measures that we were looking for the self-test specifically, a large percentage of the participants had never tested or had very little knowledge of hepatitis C in general. In terms of their satisfaction with the HCV self-test, large percentage, 93.2%, rated it very easy. The process being convenient, comfortable with the self-testing process, and trustworthy. And this is in line with what we've seen with HIV as well. In terms of the performance of the test, so that is the performance of the self-test by the participant versus the confirmatory testing by the trained observer, we can see very high positive and negative percentage agreement. So self-tests are rated as highly usable by the users, and lay users. The lay user accuracy is as good as professional administered tests when utilizing the same rapid test. So there were a lot of lessons learned during this program, and it's just the beginning for our journey in this regard. The prevalence of HCV amongst drug use populations in Johannesburg is extremely high. This is a marginalized group within our society, often very neglected. Access to HCV screening is near absent in routine public health sector. In this view, the prevalence is a significant public health challenge that we may face as a country. Centralized DAA initiation limits the number of patients who can be initiated, and doctor-centered DAA initiation, which is currently standard for the country, limits our numbers. Most of this was active infection, which really threw us quite off with high transmission risks, especially in the absence of widespread harm reduction programs. And the cost of confirmatory testing and the accessibility to confirmatory testing remains largely unaffordable for the numbers that need to be tested. So some of our recommendations for the next phase that we need to transition into is expanding screening accessibility. This project only looked at self-testing whilst observed. I do think there's merit in terms of trying to access participants or patients through non-direct self-testing, and I think there's certainly mechanisms that we can utilize for friend, partner, network referral. Implement linkage to care strategies or to build upon it and provide on-site point-of-care PCR and treatment services, integration with other services, and developing targeted community-led communication campaigns. I think what we've done on this project and others similar to this is we've lifted a lid on what could potentially be a major problem for South Africa if we do not pay enough attention to it. HCV and other viral hepatitis is being neglected, and I think this project has certainly raised the flag for the National Department of Health. So with that, thank you very much.
Thank you. Questions from the floor or through the conference app? There's a question there in the back.
Hi, Simon from Sweden. Very interesting figures. Do you have any advice what to do with all those testing positive for RNA that can't access treatment immediately? I mean, in terms of information, harm reduction measures, etc.
So all of those that we've identified as positive are now forming part of a larger global funded cohort and transitioning into the global fund program. So ensuring that that group is taken care of is one aspect of it. And Dr. Nomfundo over here is part of that program and can certainly provide more insight into what that program entails. The success of that program has been great. That program comes with a whole harm reduction strategy. So those that we've identified, we're not too concerned about them being taken care of. I think the bigger problem lies in those that we're not finding. And this group is just, there's no access at all to routine testing services. So if you're not part of the program or the cohort, chances of you getting tested until it's too late are very, very slim.
Question in the back, in the middle. There. Yes.
Hi, Louise Davis, Public Health Wales Point of Care. I was just wondering if you could explain a little bit more of how people were enrolled into it and a little bit about the observation part and how the observation.
Sure.
part.
So enrollment took place through two various settings. So we had one which was facility-based, where individuals would present to the clinic from either through network referrals. But the more interesting one was when we actually took services to them. So mostly amongst homeless groups, we'd set up testing booths or a taxi-based service. So we'd go like the combi we saw the other day. We have a very similar version of it, where we would go into the heart of where the participants are found. We'll set up a tent. In terms of the observation, we took our key from what was done for HIV. So we provide the participant with the test kit, and then the nurse observer would sit back and ensure that they don't interfere with the process unless the participant is going to harm themselves. And then we will observe we give them just the instruction for use and the self-test kit. They would then perform it as per instructions, interpret their result. If there's something that they may harm themselves, we will stop the process. If not, we'll let them complete the test. The nurse would then do the same test as a confirmatory, and then we'll do the traditional algorithm as the follow-up as well. So that in that way, we got some real-world usability on the performance of the self-test.
We have time for one more question in the front.
Hey, David de Geisel from Better Life Partners. Wonderful work, first of all. Second, I was struck by the high rate of viremic folks among the seropositive folks. Do you have any hypotheses, or is that common in Southern Africa?
Dr. Nomfundo, do you perhaps take that one?
I think it's just the high transmission. We were not aware of the high prevalence in South Africa of HCV. All along, it had been general population that is being treated. I mean, being interrogated rather to some extent. But the fact that there is no screening at all in the department or in the country for HCV as a standard screening process. So we just did not know what the burden looked like. So this is just an unveiling of something that's always been there, you know. So that's really part of the issue.
Yeah, if you have to say about 98% of the people that were tested for hepatitis C for self-testing didn't know about self-testing, they didn't know about hepatitis C, and they had never tested for hepatitis C before. It's not part of the routine program currently. So this is, I think, explaining why there's a huge undiscovered.
Okay, thank you. We have to move on. Thank you very much.